Um, Beautiful. Okay. So I just want to welcome everybody here to our lecture, our lunchtime lecture today, which has been for the last 2 years mostly a COVID conversation. This is really a COVID adjacent conversation because everything happens in the context of COVID. But today I have really the distinct pleasure of introducing a very long time friend and colleague, Dr. Yvonne Flores. Dr. Flores and I actually, we both did our master's at UCLA, but we also did our PhDs at Johns Hopkins at the same time. Mm-hmm. And we're in the same cohort, and we were in very different departments. You were in population, right?
Family health science.
And I was in the international health department. But we have lots of friends and colleagues in common, and we've known each other for a very long time. I finished my PhD in 2003. It was really 2002.
But we really are career twins.
Well, that's so wonderful. Well, it's such a pleasure to be able to welcome you. So I'm just going to read your bio very quickly so everybody has context and knows who you are and what you're doing. Dr. Flores is an associate professor in the Department of Health Policy and Management at the UCLA Fielding School of Public Health and a research scientist at the Center for Cancer Prevention and Control. She's a member of the UCLA Kaiser Permanente Center for Health Equity and the Johnson Comprehensive Cancer Center. Additionally, she has an appointment as a researcher at the Mexican Social Security Institute, where she's led numerous binational projects since 2000. She's collaborated with investigators from Mexico on several transdisciplinary liver disease related studies, including an NCI K07 project that focused on the genetic and environmental risk of liver cancer, disease and cancer among Mexicans. She's used her training in health services and epidemiology to conduct research that focuses on prevention of chronic disease and reduction of health disparities among underserved populations. She's also just a lovely person, and I'm really glad to have her here because it's a reminder that of some of the most wonderful people that we have here on campus. So Yvonne, I just am so appreciative that you're willing to give a talk here for the Center for Global and Immigrant Health. When I read your bio, I think, oh my gosh, we have lots of studies that we should be collaborating on. So we're going to set up a time to meet and talk. And with that, Yvonne, please go ahead, and the floor is yours.
Yes, thank you so much, Annie, and thank you for inviting me to give this talk, and also to the students of Color for Public Health for also co-hosting it. And it's great to be here. Again, I'm sorry that this is not a talk about COVID, but like I mentioned before, we were going to be doing supposedly a COVID vaccine interchangeability study at the Eames office where I work in Mexico, and that has been in the works since August and has not manifested itself. So at this point, I'm thinking it's not going to actually happen because people in Mexico are already interchanging vaccines. Like people are already getting vaccinated with one vaccine or the other, and they're just not, they're like, whatever's available, that's what you get. So they're already doing it, but not necessarily studying it, which I think is unfortunate, but at least people are getting vaccinated. So that said, our talk, my talk today will be about the research that I've done to investigate liver disease and liver cancer disparities here in the United States and also in Mexico, and how it is that I've used like different approaches, some of which are more like health services research approaches, and some are more epi approaches, and some are more basic science approaches to look at this problem which affects Mexicans in both countries and Latinos in the US. All right, so then let's see, why is this not advancing? There we go. So in terms of how the talk will be structured today, I'll talk a little bit in terms of the background of like the prevalence of liver disease worldwide, in the US and in Mexico, some of the research that I've done here in the US by national studies where I've looked at liver disease risk factors in both countries, research that's specifically been focused on in Mexico, current and future studies, and then I'll save hopefully some room for questions at the end. And I'm sorry if I go pretty fast, but this is like a lot of stuff, and this is like the condensed version of the talk, and I have like, that doesn't even include a bunch of other studies. But so, and also if someone has a question, like just also feel free to interrupt me if you have a pressing question and can't wait till the end. So in terms of the global burden of liver disease, it is a significant problem. Non-alcoholic fatty liver disease, which is caused by overweight and obesity, affects approximately a quarter of the world's population. In the US, it's supposedly 1 in 3 people who potentially have non-alcoholic fatty liver disease. Worldwide, liver cancer is the 6th most common cancer. There's approximately 2 million deaths due to liver disease and liver cancer a year, and it's the 2nd most common cause of cancer death. So the issue with liver cancer is that it's extremely fatal. It's the 5-year survival rate is only 20%. So if a person gets liver cancer, they're highly likely to die of it. And the mortality due to liver disease and cirrhosis, which is an advanced form of liver disease, varies from country to country. It's highest in Egypt. It's very low in, say, a country like Iceland. In the United States, it's more like a mid-range, closer to like being on the low range. And in Mexico, they have the highest mortality rate of Latin America. So it's a major issue in Mexico. And that's actually one of the reasons why I began to study liver disease, is because it's one of the main causes of death in Mexico. So this slide shows, which is extremely busy, and I don't expect you to like necessarily understand all of it, but it shows how, based on the region, there's different risk factors that are contributing to cirrhosis, whether it's alcohol, which is in blue, hepatitis, which is hepatitis B, which is in red, hepatitis C, which is in green, or other, which generally refers to non-alcoholic fatty liver disease or other contributors to cirrhosis, but others generally that. And so you can see on the right-hand side, or on the left-hand side, on the left is Asia. There's more red, which has to do with hepatitis B, and in Africa, there's also more hepatitis B. But in this sort of central area here, which is Latin America, you can see that there's more liver cirrhosis that's due to non-alcoholic fatty liver disease, which is this, and here in the United States as well. So that's one of the risk factors that I'm very interested in. So even though the geographic prevalence, for example, of hepatitis B isn't that much of a problem in Mexico and the United States, the way it is in Asia and Africa, that is a more important cause of disease in that area of the world. So, however, in the United States, as you can see from this also very busy graph, but all you really need to know is that, and this is one of the reasons why I work in this area, is that liver cancer is one of the few cancers that's actually increasing. A lot of the common cancers over time have been shown to be decreasing. The incidence of these cancers is decreasing. So something like prostate cancer or colon cancer, stomach, cervix cancer, these are cancers that are not necessarily increasing, and that the mortality rates are also decreasing, but liver disease is a cancer that you're seeing increase over time. So that's one of the reasons why I'm interested in this disease. So in terms of the burden of liver disease in the United States, over time, it's just been increasing. There's approximately 40,000 new cases per year and 30,000 deaths in the whole country. However, in LA County, it is the second leading cause of death for Latino males. So I think that's a very localized sort of issue and problem that I'm interested in, also in terms of like doing research on this issue in Los Angeles. So this slide shows how this liver cancer is also a disparity issue. So you can see at the bottom of this figure is whites, which have the lowest incidence and the lowest mortality due to liver cancer over time. And then you have African Americans who have a lower incidence and mortality than Latinos, which is the yellow, and Native American Indians and Alaska Natives who have the highest incidence and mortality to liver cancer. And you can see how over time, mortality, which used to be higher for Asians, has gone down, and that's because of the hepatitis B vaccine, which was introduced in the 90s. And so you've seen a steady decline over time in liver cancer due to hepatitis B in Asians and some other populations. All right. In terms of the incidence rates and death rates by race ethnicity, as I mentioned, American Indians have the highest incidence and mortality rates, followed by Latinos, and then Asians, Blacks, and then whites have the lowest incidence and mortality to liver disease in the United States. And as with the other graph that I showed with the risk factors and how it is that they vary from country to country or region of the world, in the United States, you also have different risk factors. The prevalence of risk factors varies from population to population. So excessive drinking, which is obviously a risk factor for liver disease, is highest among Latinos and whites. Hepatitis B, the proportion of acute cases being of hepatitis B being diagnosed is now currently highest among whites. And with hepatitis C, it's highest among American Indians and Alaska Natives. Obesity is high in most groups except for Asians. However, as you can see, Blacks have the highest proportion of obesity, yet they don't have the highest rates of liver disease caused by non-alcoholic fatty liver disease. So that's something that I find rather fascinating. And that's one of the reasons why I do research that also examines genetic risk, because even though the proportion of obesity is higher among Blacks, and don't get me wrong, I mean, among Latinos, it's pretty high too, it's at 45%. You're just not seeing the same prevalence of liver disease or mortality that you'd see among Latinos or American Indians and Alaska Natives. And diabetes is the most prevalent among American Indians and Alaska Natives. And so I think this next slide is also important to sort of document how it is that among all races and ethnicities, you are seeing a decreasing trend in the incidence of colon cancer, which is a major, one of the major cancers. All race and ethnicities, you're sort of seeing a decrease over time in colon cancer, whereas on the right-hand side where you have the rates for liver cancer, there's more of an increase over time for all race and ethnicities, except for Asians, it's more of a flat line because that their liver cancer is one of the main factors for it is hepatitis B. So that's a factor that's being addressed by the hepatitis B vaccine. So unlike colon cancer, rates for liver cancer are on the rise. All right, so then this is one of the first liver disease research studies I did in the United States when I was doing my postdoc here at UCLA after getting my doctorate. And this was a study that examined risk factors for chronic liver disease in Blacks, Mexican Americans, and whites using data from NHANES. And so I was curious to find out Because, and this was actually the first paper that looked at disparities in risk factors for liver disease by race, ethnicity in the United States. And I was at the time pretty shocked that there wasn't this kind of information, but I'm glad there wasn't, because then I was able to like write the first paper that sort of like examined these differences by race and ethnicity. And so what we looked at is the prevalence of known risk factors for chronic liver disease, including elevated liver function test results, hepatitis B and hepatitis C infection, alcohol intake, obesity, diabetes, metabolic syndrome, and we looked at these by race, ethnicity. And so our sample size was almost 18,000 people. That was approximately 5,000 Black, 5,000 Mexican Americans, and 8,000 whites. And so what we found was that men, African American men, and Mexican American men and Mexican American women definitely had a higher prevalence of elevated liver function test results. Mexican Americans had a lower prevalence of hepatitis B, while Black women had a higher prevalence of hepatitis B or C. Heavy drinking was found to be heavier among Mexican American males and lower among Black and Mexican American females. Obesity was highest among women who were either Black or Mexican American, and diabetes was high among Mexican American males and females and Black females, and then metabolic syndrome was pretty much just lower among Black men. So we did find that there were different risk factors by race ethnicity, with Black and Mexican American males and females having multiple modifiable risk factors for chronic liver disease, with the following exceptions, which I mentioned, but that Mexican American and Black females are less likely to drink, and Black males are less likely to have metabolic syndrome. Now, the drinking is sort of like a risk factor that I don't necessarily think is still true. I think there's more drinking going on these days. And these were data that were from NHANES 3, so they're not as new, but there were the data that was available at the time. Another study that we did more recently was we looked at liver, HCC stands for hepatocellular carcinoma, which is liver cancer. And so we looked at liver cancer disparities by also race and ethnicity in terms of incidence, stage, and survival. However, for this study, which used SEER data, we also included SES. So we wanted to examine the relative impact of race, ethnicity, sex, and SES on these critical measures that are associated with liver cancer. And so what I did is we identified histologically confirmed cases of liver cancer diagnosed between 2000 and 2015. And what we found was that, with few exceptions, HCC incidence, advanced stage, and poor survival were highest among the low SES groups for all race and ethnicities. So we thought this was an interesting finding, because usually race and ethnicities are lumped together. And even though it is sort of, been demonstrated before that people who are in lower SES groups have worse health outcomes, I mean, this was also the first study to sort of like showcase this with incidence, stage, and survival outcomes. And so what we can see here in this graph is that for every single, and these results are significant for all race and ethnicities except for American Indians and Alaska Natives, just because the sample size for that group is significantly smaller than it is for the other racial and ethnic groups. But you can see the low SES groupings are in blue, and they're always have higher incidence no matter what their race, ethnicity. And the highest incidence of liver cancer, as you can see, is in Asians or Pacific Islanders, followed by Latinos, then Alaska Natives and American Indians, Blacks, and whites. And this next slide, which do not feel like you need to follow. I mean, the graphs are just there for illustrative purposes, but you also see that survival, which is, this blue line for the low SES, is always worse in the low SES groups than it is for the high SES groups, which is the gray, except for among American Indian and Alaska Natives, again, because of the sample size issues. But other than that, for the other groups, survival was always worse in the low SES groups. And that the Black low SES males had the lowest 5-year survival. So here, these graphs show males and females together, but we did this exact same analysis by sex for males and females. And of all groups, the ones that had the lowest survival were Black SES males. And so we reported in our manuscript that these results reflect how specific social determinants of health and structural racism can lead to health inequities. And so another project that we're working on here at UCLA to understand liver cancer disparities is a project that's been funded here with UCLA funding to inform precision health approaches to address liver disease and liver cancer, address health disparities, enhance disease risk prediction, and also provide insight about liver cancer, how liver cancer develops in the first place. And so this is the team of investigators that is involved with this study. And part of this, and this is only like a fraction of the team because there's just a whole bunch. But the whole purpose of this project is to promote collaborative interdisciplinary work, not just here at UCLA, but with other UCs as well. And so the first aim of this study is to examine racial and ethnic differences in liver disease risk factors and liver disease rates, and the receipt of surveillance and treatment among UCLA primary care patients using EHR data, which is electronic health records data. So it has been probably the most challenging thing of my life to work with electronic health record data. But that's like a sidebar conversation, but it has been, let's just say that it is a lot easier to collect your own data than it is to examine data that's in an EHR. So what we're doing with this study with great difficulty is comparing risk factors in clinical management by sociodemographic characteristics. We're examining best practices for management and surveillance among high-risk groups and patients with liver disease. And the whole purpose of the study is to try and develop algorithms for risk stratification to inform precision health approaches. And our aim too, which is the aim that I've been the lead for, is looking at metabolic dysregulation and risk of non-alcoholic fatty liver disease among Mexicans with samples and data that we collected from a cohort study in Mexico that I'll go into a bit more detail when we talk about the studies in Mexico. But basically what we did is we looked at 98 NAFLD cases and 100 healthy controls from a cohort study that we have in Mexico, and we determined the association between metabolic dysregulation and risk of NAFLD using questionnaire, clinical, and laboratory data. So in terms of the first aim, where we're examining racial ethnic differences, what we did was we identified a cohort of primary care adult patients seen at UCLA between 2006 and 2019, and we're now getting this data updated, and we'll have data through 2021, but that's another story. And so the eligibility to be in our cohort to begin with is that you have more than one primary care visit, and that these visits are not more than a year, approximately a year apart. And we assembled this cohort of adult patients with liver disease also using ICD-9 and ICD-10 codes. So what we have is two sets of patients, one which is a primary care cohort, and then another is within that primary care cohort, patients who have liver disease. And so in terms of like the cohort characteristics, comparing the primary care cohort, which is over 280,000 patients, to the liver disease cohort, which is close to 28,000. So this is approximately 10% of the patients have liver disease. You can see that most of the patient population is white, which is how the racial and ethnic breakdown of UCLA is. Most of the patients here are white patients. In terms of the proportion of patients with liver disease, we have 15% who are Latina or Latino, 13% who are Asian, and 7% who are Black. And then we obviously have these unknown or other categories. And these are the cohort characteristics by the racial and ethnic breakdown of the different liver disease categories that we've examined. And so in terms of like NAFLD and NASH, we see the highest prevalence of NAFLD and NASH among the Latino patients, followed by Asian patients. With hepatitis C, we see that Blacks have the highest prevalence of hepatitis C in this patient population. And Blacks also have high prevalence of cirrhosis, but Latinos have the highest prevalence of cirrhosis in this population. And the hepatitis B, which is not unexpected, is highest among Asians, as is liver cancer. And now over time, these trends in terms of the prevalence of hepatitis B and liver cancer being highest among Asians is going to change because of the hepatitis B vaccine. We also see that based on the EHR data that Latinos also have the highest prevalence of alcoholic liver disease. So we're seeing alcoholic liver disease, cirrhosis, and NASH in this particular patient population be highest among Latinos. And so in terms of AIM-2, where we're looking at the metabolic dysregulation and risk of NAFLD among Mexicans, like I said, we're looking at 98 cases of NAFLD and 100 healthy controls, and we're comparing their profile in terms of metabolomics and lipidomics. So the NAFLD cases in Mexico were clinically confirmed using elevated liver enzyme tests, as well as liver ultrasound or fibroscan after excluding any kind of potential alcohol abuse. Controls had at least 2 consecutive liver function test results that were normal in a 6-month period, and they also were confirmed using fibroscan, which is a type of liver ultrasound that's used to diagnose disease. And the samples were analyzed at the UCLA lipidomics laboratory by one of our collaborators, who's Stephen Bensinger, and at the UCLA Metabolomics Center with Dr. Tom Graver. And so the findings of this study were published last year. So this is something that we just recently did in the Journal of Lipids in Health and Disease. And this was a completely new area of research for me. So writing this paper was really quite challenging because I'm not a lipidomics expert, but I am interested in trying to understand and identify why it is that Latinos and Mexicans in particular have such a high rate of non-alcoholic fatty liver disease and subsequent liver cancer. So what we found in this study was that we looked at 1,100 lipids, and we found that none of the top 20 lipids, which were identified by a technique called random forest analysis, predicted case control status better than an area under the ROC curve of 75. But after adjusting for age, sex, BMI, and PMPLA3, which is a particular SNP genetic variant that puts individuals at higher risk of NAFLD, a panel of 10 lipids was able to predict case control status better than an area under the ROC curve of 0.83. So this this graph down here shows the top 20 lipids in terms of their being different, significantly different between cases and controls after adjusting for age, sex, BMI, and PMPLE3 genotype status. And then here is the ROC curves that show how it is that a model that includes the top 10 lipids plus some of these other covariates is able to predict case control status at what's considered a pretty elevated clinical relevance rate. All right, so the next findings have to do with metabolomics. This is a typo. It should say metabolomics instead of lipidomics, I'm sorry. But again, individually, none of the top 20 metabolites, and here we looked at 150 or so metabolites, and individually, none of the top 20 metabolites were able to predict case control status better than an area under the ROC curve of 70. However, after adjusting for these covariates, a panel of 10 metabolites, the top 10 metabolites were able to predict case control status better than 90%. So that is very clinically relevant finding. If you could, with just this, these variables, identify patients who have NAFLD versus patients who do not, that's a pretty high sensitivity rate to have. And so this also shows the top 20 metabolites that we found and presents the ROC curve analysis results. All right, so now I'm going to briefly talk about some of the binational liver disease research that I've done, where this was done about 10 years ago, where we looked at risk factors for liver disease and associated knowledge and beliefs about liver disease among Mexicans living in the United States here in LA and in Cuernavaca, Mexico, which is where I work at IMSS in Mexico. And so this study was funded by the Johnson Comprehensive Cancer Center, and Dr. Bastani and I were co-PIs on this study, which basically contrasted the knowledge and beliefs and risk factors related to liver cancer and liver disease among Mexicans in Mexico and here in LA. And so what we did for this study is we interviewed 100 men and women in California and 126 men in Cuernavaca. And half of the study subjects in Mexico were recruited at a clinic setting, and the other half were recruited in the community. And we specifically interviewed participants who were born in Mexico, were native Spanish speakers, and were between the ages of 18 and 70. And so basically, what we asked in a questionnaire was, we collected socio-demographic data, information about their acculturation level, their risk factors for hepatitis B and C, other risk factors for liver disease, knowledge about risk factors of liver disease, attitudes and beliefs about liver disease, intervention preferences, and we also took their weight and height to estimate their BMI and their waist circumference. And so what we found here was, this is just a description of the study population, which is the mean age was approximately around 40 years of age for people in Cuernavaca, but also here in LA. And the sample in Cuernavaca was more well-educated than the sample in LA. And the income also sort of varied, obviously, between Mexico and LA. And so our main findings were that Mexicans in LA and Cuernavaca have similar risk factors for liver disease and cancer. And some of these factors include high levels of overweight and obesity. The mean adjusted BMI was close to being obese. They had low levels of screening for hepatitis B and hepatitis C. The prevalence of heavier binge drinking was actually 36%, which was higher than is reported in national surveys. And there was more drinking among males than females. And there was also a high prevalence of self-reported diabetes in this, what was a small sample, but was nonetheless reported a high prevalence of diabetes, higher than in national samples. Another study that we conducted, which was with a much larger sample, also compared risk factors for liver disease among adults in Mexico and in the US. So this was sort of like a continuation of the previous study, but just with a much larger sample size. So we compared the prevalence of chronic liver disease risk factors in a representative sample of Mexican Americans who were born in Mexico or the US here using NHANES data, and a sample of adults who were born in Mexico with our cohort study data. So we used data from NHANES from 1999 to 2014, and we had approximately a sample size of 4,200. We used data from the Mexican health worker cohort study in Mexico, and we had 10,000 participants for that. And we used regression analyses to investigate chronic liver disease risk factors. And so here we have like the study sample characteristics. And you can see that most of the participants were between the ages of 20 and 44. Most were married. And the sample in Mexico actually was more well educated than the sample in the US. So you can see here in the Mexico sample, which is this column and this column, the participants who had more than a high school education was closer to 60, whereas the Mexicans who were in the United States but were born in Mexico had a lower education rate than those who actually were first generation, who were born here in the United States. So this is in terms of the education. So there was a difference in education between the US born Mexicans in the US versus those who were born in Mexico. And so in adjusted analyses, what we found was that Mexicans in the US were significantly more likely to have diabetes, obesity, abdominal obesity, and be heavier binge drinkers than their counterparts in Mexico. And US-born Mexican Americans had a greater risk of metabolic syndrome, while Mexico-born Mexican Americans had an increased risk of high cholesterol. So Mexicans, this study, which was conducted with a much larger sample size than the prior study, found that Mexican Americans who were in the United States definitely had more risk factors for chronic liver disease than their counterparts in Mexico. So this next slide is in Spanish, I'm sorry, but I'll translate, which just shows the burden of liver disease in Mexico. And the fact that this is also a major problem in Mexico, not just in the United States, but you can see that in Mexico, liver cancer is actually the third cause of death due to cancer, whereas here in the United States, it's not in the top three at all, and worldwide it's number 6. And you are able to see that there were 7,000 cases of liver cancer and approximately almost 7,000 deaths from liver cancer in 2018. And that's because people in Mexico are more likely to die of cirrhosis than liver cancer. So, to get liver cancer, you first have cirrhosis for the most part. So cirrhosis is a precursor to liver cancer. But in Mexico, a lot of people die of cirrhosis instead of having the cirrhosis develop into cancer. So these are people who are dying prematurely before they are even able to develop liver cancer. So in Mexico, cirrhosis is responsible for the deaths of almost 40,000 people and approximately a third of these deaths are due to alcohol. And as I mentioned, cirrhosis and other liver diseases are the number 4 cause of death in Mexico, the number of death overall, not just cancer death, but just death overall. And that's also not the case in the United States. Liver disease is not one of the top 10 causes of death for the general population, but it is more so for Latinos. And in Mexico, liver disease is the 3rd cause of death for males between the ages of 35 and 65. So it really is a major burden in Mexico, more so than in other countries. And so then just briefly, because I know we've covered a lot, the liver disease research that I'm involved in Mexico has to do with this cohort study that we've had for almost 20 years, which is the health worker cohort study of Ames health workers. And we've had 3 waves of data collection in 2004 to 2006, 2011 to 2012, 2017 to 2018. And we're supposedly in the process of hopefully getting funded for the next wave of data collection, which supposedly was supposed to happen 2 years ago, but because of COVID, it's been delayed, but we're supposed to be starting the next round of data collection, hopefully this year or next year. And so the aim of this study is to investigate the role of various lifestyle factors on the development of specific chronic diseases, including liver disease. And so we're following up approximately 2,000 healthcare workers and their relatives over time, and the age ranges from 8 to 85. And so we also collect the following information on sociodemographic data, risk factors for hepatitis B and C, and other risk factors for liver disease, knowledge of risk factors, prevention practices, and also information about their intervention preferences. So this study, and some of the results that I'm reporting seem like they're repetitive, but it just is to sort of like show how it's the same risk factors that affect the Mexican American population, whether it's here in the United States or in Mexico. But so for this study, we examined data from 2 waves of data collection, 2004 and 6 to 2011 to 13, and our sample size of 1,400 patients. What we looked at were obesity, metabolic syndrome, diabetes, and alcohol consumption. And so we used unconditional logistic regression models to examine the cross-sectional and also the longitudinal association between these risk factors and having an elevated liver function test result. And so what we found was that elevated ALT was significantly higher among males, individuals who were under 60, those who were obese or overweight, diabetic, and had metabolic syndrome, or who were heavy or binge drinkers. And we found similar results in the longitudinal data, which is that weight gain that resulted in a change of BMI category, along with remaining overweight or obese, were also significantly associated with an increased risk of having elevated liver function tests. And a significant increase in risk of developing elevated ALT, which was also observed among those who acquired or became diabetic or who had metabolic syndrome from one wave of data collection to the next. Very briefly, because this would be a whole other talk. I was awarded an NCI Career Development Award to examine the genetic and environmental risk of liver disease and cancer among Mexicans. And so what we did is, using data from our cohort study, we examined 207 cases of patients who had elevated ALT or AST, which is equated with having non-alcoholic fatty liver disease, and 534 controls from the cohort study. And we found that this polymorphism, this genetic variant, PNPLA3, was associated with a 2-fold risk of having elevated liver function tests. And among the obese or overweight participants, these particular polymorphisms were associated with a greater risk of chronic liver disease. And so we have like several publications having to do with this study. And so currently I'm working on with another UCLA investigator, Hiram Beltran Sanchez, who's in CHS, and he's also from Mexico. We're investigating liver disease related mortality among Mexican adults in the United States and Mexico. And so this is like the first study that will longitudinally compare liver disease related mortality, liver cancer, and cirrhosis over the past 60 years among Mexican adults in the US and in Mexico. And we're also predicting future mortality trends in both countries to 2050. So we're using WHO detailed mortality files for 60 years of data in Mexico and a little bit over 60 years in the US. And in the US, we're also using and CHS data to differentiate between major racial and ethnic groups from 1968 to 2013. And so we're comparing, we're estimating and comparing age standardized chronic liver disease mortality rates for each year. And then we're testing for significant time trends by sex in both countries and by major racial ethnic groups in the US. And then we're predicting these results. This is something that's ongoing. We haven't finished predicting the mortality over time, but we finished the analysis of the WHO data. So now we're just doing the predictions. And some future research studies that I'm interested in doing is continuing to analyze SEER and NCHS data and possibly Medicaid data, this electronic health record data that I will be like immersed in for the rest of my career, most likely, and then also potentially participating in intervention studies to help patients who have non-alcoholic fatty liver disease. And this is a list of some of my collaborators here at UCLA and in Mexico, and also at the National Institute of Public Health in Mexico. And that's pretty much it. I don't know if anyone has any questions or.
Does anybody have any questions? Let's see. Questions?
I know that was a lot, but
That's so
I feel like I finished on time.
That's amazing. This is really, I mean, Yvonne, I'm just so blown away by all the work that you've been doing. And I just think, you know, this issue, as somebody who's an infectious disease epidemiologist, and most of my work has been in this, you know, side of it, I'm really, this once again brings up to me how important the chronic aspects of disease are, and how you and I are going to need to do some studies where we're looking at the intersection.
Mm-hmm. Yes, absolutely. And there is an intersection in the case of liver disease, because there is infectious factors like hepatitis B or hepatitis C, which also are increasing among the white population because of the opioid epidemic. And so, so risk factors change over time. And what I have found extremely depressing over time is also how, like, every year we really do get fatter. Like every time I update the like obesity prevalence data, it is every year higher. So like 10 years ago, it was like in the 30s, and now it's in the 40s. And then in 10 years, it'll be in the like 50s or in the 60s. So like, I mean, you all probably know this, but like Mexico and the US are constantly competing about like who has the highest prevalence of obesity. So we're not doing that great in that area.
It's all changing, and the risk factors are changing, and the epidemiologic landscape is changing. And I think, you know, you and I, as people who worked in global health, always, you know, we always talk about the changing global epidemiologic landscape, but I think we never really thought about it in terms of how it applies to us, how it applies to high resource settings, and you know, I just think that all of this is so critical and important. And so I think that this intersection, especially for our students that are coming in here, you know, I think that so many students have, you know, we always have a tendency to say, oh, I'm interested in infectious disease, oh, I'm interested in chronic disease, you know, and kind of parsing things out in that way. But as in so many things, the borders are blurred, and everything is impacts everything else. So truly just so fascinating. Well, if we don't have any, oh wait, we do have a question, Sierra.
Hi, yeah, I was wondering, you mentioned that you evaluated acculturation in the US Mexican American population. How did you approach that?
That was a while ago, so forgive me if I don't remember it, and I'd be happy to send you this information. But what we did is we asked like your typical acculturation scale questions. I think it's like 10 or so where you ask like, are you more comfortable speaking in English or in Spanish? Are you more comfortable, when you're with your friends, do you spend time with people who speak more English or Spanish? Do you speak Spanish at home? Do you speak Spanish at work? Like how it is that people communicate. There's a whole acculturation scale. So I'm pretty sure we use that. I don't know that we, that was explaining a lot of our results. Like, I mean, if we looked at, I don't remember, I know we collected the data, I know we had it, but I don't remember it making a difference. Like the people who were acculturated versus not acculturated had different risk factors. But what we did find in the follow-up study that used, nationally representative NHANES data to look at Mexicans who were born in the US versus Mexicans who were born in Mexico, there were very drastic differences between those two groups in terms of risk factors. And I mean, there's clear differences between someone who was born here versus who was born in Mexico and emigrated.
Thank you.
Sure.
Fantastic. Any other questions? Well, we're right at time and students are gonna have to go to class in a second. So Yvonne, what a pleasure. Thank you so much for your time and expertise, and we'll have to catch up soon.
Yes, absolutely. Oh, wait. Thank you so much for having me. And
Thank
happy
you.
Public Health Week. We
Yes.
can all celebrate each other.
That's exactly right. Thank you so very much.
All
Okay,
right.
bye everyone.
Take care.
Thank you so much, Dr. Flores.
Thank you for inviting me. Bye.